Hello team, how are you?
Hi, good morning. I mean, good afternoon for you. How are you?
Can you hear me team?
I can hear you well. I would
Ses
like
geliyor, I can
to
hear you diye
turn
duyuyorum
on
ben.
the video.
Laptop'tan mı geliyor?
For some reason, I'm not allowed to turn on the video. If they can allow me to turn on the video, would be good.
Dışarıya verelim onu.
The host,
Sesi verebilir miyiz bir salona? Doktor konuşuyor da.
I can share the screen. I cannot turn on the video.
Dear Doctor, hello. My name is Doğukan. I am on digital marketing team in Live Hospital. Can you hear me?
Very well. Good morning. Good afternoon.
Good afternoon. Thank you. Good morning.
Okay. Yeah. Do you see my screen?
Yes.
Yes.
Okay. You
We
know,
can
I
see
could not turn on the video. If you don't want me on video, it's fine, but I am not, it says the host has to allow me to turn on the video.
Which video you can't play?
You know, we're talking the face, so you can see me.
Yeah, okay. No problem.
If you want. I mean, you know, you don't need to, but
It doesn't matter, whatever you want. It's okay for us. So can we wait just 1 or 2 minutes and then we can start, okay?
okay, sounds good.
Thank you so much.
Yeah.
Videoları nedir?
Yeah, so I still I cannot turn on the video. So for some reason, the settings that you have, you cannot see me because I am not allowed by you to turn on video, which is fine. I just want you to know that's the reason you cannot see me. You can only see my picture. If you go to start video, I get a message, you cannot start video because the host has stopped it, the host being you.
Yes, you can open. Yes, we can see you.
You can see me now? Okay,
Yeah,
perfect.
Perfect.
All right.
Okay. Just 1 or 2 minutes and then we can start, okay?
Absolutely. Whenever you say okay.
Okay, thank you. Dear doctor,
Hello again. Welcome. Thank you very much, Axel, for our invitation.
Hello, can I start? Hello, can I start?
dear doctor, you can start.
Okay, perfect. Good morning and good afternoon. I'm Tim Murgo. I work at the University of Chicago. Thank you for the kind invitation to participate in your hospital's meeting. It's truly a pleasure to give lectures to the peers of my friends and people who do the same thing that I do, which is interventional pulmonology. I surely hope that you're all doing well and that in the near future we have the opportunity to meet in person. Until then, I hope this will suffice, and hopefully you find this 20-minute lecture somewhat relative for your practice. It is an update on navigation platforms and robotic bronchoscopy. My disclosure is that I am a consultant for several device manufacturers, including the robotic bronchoscope that I've been using now since 2018, which is the Monarch system by Johnson & Johnson. So with that disclaimer, I will go into the outline of my lecture. I will start by summarizing the literature on guided bronchoscopy, very brief overview of landmark literature. Then we'll talk about why robotic bronchoscopy, why do we need these platforms, and do we need them? Are they any better than what we already have? So we'll have a critical look at the literature that's been published to date on robotic bronchoscopy, with particular attention on how we define diagnostic yield. Because looking at the literature in detail and being part of a national study, looking at the outcomes of robotic bronchoscopy, we came across a variety of publications, and we realized how different studies are in regards to how they define diagnostic yield. And then towards the end, we'll illustrate how we apply robotic bronchoscopy in practice with a couple of images. So first, we're talking about navigation systems and guided bronchoscopy in general. Just one slide on this, the radial endobronchial ultrasound is really not a navigation system per se. You need to get to the target based on whatever platform you use, or your own knowledge of the anatomy. And to confirm you're there, the 20 megahertz radial scanning probe will show you a nodule or lung parenchyma. It's really not too many other images that one can get. But if you are at the nodule and you get an image like this, then diagnostic yield is known to be about 80%. If the lesion is just outside of the airway, diagnostic yield is somewhere in the 40%. So we know this now for many years, to the point that even in 2013, the ACCP guidelines recommended radial EBUS for patients who were suspected of having lung cancer and need a diagnosis prior to surgery. Since then, there have been many other studies, including meta-analyses. There is a meta-analysis published in Chest by Dr. David Ost from MD Anderson just last year or 2 years ago, I think 2020, looking at the variety of studies on radial EBUS. So I will not spend a lot of time on it. It's a well-established technology. The only issue with that is, how can you get to the nodule to put the radial probe in? Can we get lost towards going to the periphery of the lung? So that's why there are other modalities that will take us there, the so-called navigation systems, right? And until a few years ago, there were two systems available on the US market. One by Medtronic, known as Super Dimension, the other one by Veran, which is now part of Olympus Corporation. And there is good data on both of them. Again, to the point that the American College of Chest Physicians recommended navigation bronchoscopy for difficult lesions, the ones that are difficult to reach with conventional one. And with or without fluoroscopy. And that was a grade 1C recommendation, which means the benefits outweigh the risks, but the studies were not that powerful, not that strong. When the recommendation is labeled as C, that means the evidence is based on observational studies or case series, not randomized controlled trials. Again, this is 2013 guidelines from ACCP. Since then, there have been numerous studies. The largest one on navigation bronchoscopy was published by Eric Falk. I am one of the co-authors on the Navigate study, just published last year in Journal of Thoracic Oncology, looking at more than 1,000 patients using the super dimension system. But when you start looking at all these studies together, including meta-analyses, the yield of these interventions, guided bronchoscopy with radial EBUS, virtual bronchoscopy using a thin scope, or electromagnetic navigation, we're looking at a yield of about 73%. And that's in meta-analysis of studies that may be prospective or retrospective. In the cleaner studies, if you want, in studies that are randomized and prospective, the yield may actually be even lower. For instance, one study here by Nicole Tanner, working with Dr. Silvestri at Medical University of South Carolina, compared radial EBUS with a thin bronchoscope with fluoroscopy for peripheral lesions, and the yield was about 50% with no difference between the two. Now, the one caveat to the study, the sampling in the peripheral lesion did not always involve needle, but still the yield is not as high as in meta-analyses. Same thing for the acquired registry data published in the Blue Journal back in 2016 that showed the yield of electromagnetic navigation of 40, I think it was 38%, and with the radial EBUS was about 47%. So still much lower than what was reported in like retrospective studies or in other meta-analyses. The studies I just mentioned to you by Falk, the Navigate study, showed a yield of 73%. But we're still lower. When you look at all these papers from bronchoscopy, we're still lower than a CT-guided biopsy that gives us a yield of about 90% of, for cancer for lung lesions. Sure, there is the caveat that we don't stage the mediastinum when we do just CT-guided. There is a higher risk for pneumothorax. But if you're just referring to the diagnostic yield, that is higher with the CT-guided than what we know so far in terms of navigation platforms. So then the idea of introducing these systems that will take you to the lesion based on some navigation system while you see the airway as you go towards the periphery. These modalities are called robotic bronchoscopies. There are two systems on the US market right now, one by Oris, but that's now Johnson & Johnson, and the one by Intuitive. The idea is that the operator controls the bronchoscope. These are not self-sufficient tools, okay? They are still operated by an individual, and they navigate towards the periphery of the lung, and then once they're at the nodule, then the individual can work at the nodule, having a stable system. They both have pros and cons. We actually published a review article in 2020, and we're actually working on an updated one as we speak. But if you want a reference to look at the pros and cons of the two systems, you can find that in Journal of Thoracic Disease in 2020. They're both allowing one to introduce the radial EBUS probe. They both use fluoroscopy, and they can all take you into the periphery of the lung. In fact, with the Monarch system, we know that we can get up to the 9th generation airway, even though, and that's actually further out than we can go with the 4.2 millimeter bronchoscope. So the size of the robotic bronchoscope from a Monarch is actually 4.4 millimeters, and still you can go further than with the 4.2 millimeters. So you may say, how is that possible? Well, because the robotic bronchoscope has a sheath, and then that's stabilized, and then through the sheath, the actual scope goes further. So the airway, the peripheral airway is somewhat partially dilated as we're advancing and pushing the bronchoscope towards the periphery, which is different than a regular bronchoscope that may bend, that may buckle at the level of the carina, and as you push, it bends right there. So that is the big difference. Look at that. This bronchoscope is 4.2 millimeter. This is 4.4 millimeter, and you can go actually further. In terms of how they work and to take you there, the so-called navigation system, the intuitive system and the Johnson & Johnson system, or the ION and Monarch, they are different because they use different technologies, and without going into details, they are both prone to some errors because they use a CT scan that was performed in a completely different condition. So when we do these procedures, we do them under anesthesia with the patient supine and completely relaxed, intubated, positive pressure ventilation. The CAT scan for planning these interventions is performed with the patient taking a deep breath, spontaneously breathing with a total lung capacity. So the map that we're using is based on a lung volume that's completely different than when we actually do the procedure. So I don't think that any company can say that one technology is better than the other in terms of the navigation unless they truly have the evidence to support that claim. Because they both have this error, the so-called CT to body divergence, just because the CT scan is done in a completely different situation. So, I mean, this is when we do the procedure. We do the procedure when the patient is breathing, from a functional residual capacity, while the CAT scan is done at total lung capacity. And in fact, there are a couple of papers now, and they are listed here on the slide, one in Chest and one in Journal of Thoracic Disorders, that show that during general anesthesia, for these procedures of navigation bronchoscopy, there is actually quite a bit of atelectasis. So the lung starts to collapse in segmental airways, which is not to be ignored. I mean, look at the percentages. And we see that with the prolonged anesthesia, so usually after about 30 minutes of anesthesia, and we see that with increased body weight. So with the obese patients and with more anesthesia, the lung will continue to collapse. So the lung will shrink even more. So the CT to body divergence will be even worse. Not to mention that when we insert the radial probe, sometimes we can look at areas that are atelectatic and they may look like tumor. So we may get false positive radial EBUS imaging. So quickly again on the differences between the systems, the Monarch system, the outer diameter is 4.4 millimeter, the ION is 3.5, so smaller, so it potentially can go further in the lung. They both can move at 360 degrees, the so-called articulation. The Monarch system has a sheath and a scope, so therefore it's a little more stable than the ION system. That's just one scope. That's a personal view from reviewing videos. It's not necessarily an evidence-based statement. But then the major difference that's just based on the way the systems are designed is that with the Monarch system, you have a working channel and the camera, so you can insufflate air, saline, whatever, as you're actually navigating in the periphery of the lung. With the ION, you cannot do that because the working channel is occupied by this scope. And then you take the vision probe out and then you work at the target without vision. So that's actually one of the potential disadvantages of the system, that work at the target, work at the nodule is actually done blindly. So now what does the data say in terms of diagnostic yield? What you see highlighted in red here is the literature on ION system. What's in blue is the literature on Monarch system in terms of diagnostic yield. So they may look the same. Maybe the ION may actually look better according to this paper, although they use cone beam CT as well, it was not just a robot. The major problem that we're seeing with these definitions of diagnostic yield is that people define diagnostic yield in different ways. So I want you to spend 1 minute looking at this slide, because I think we all agree that if you get cancer, or if you get a specific infection or granulomas or a hamartoma, we all agree we have a diagnosis from a peripheral lesion, right? So malignancy or a very specific benign. We also agree that if we just get bronchial cells or normal lung or reactive bronchial cells, that's non-diagnostic. The issue is, in studies looking at bronchoscopy, what people do with these findings here in yellow. How does one classify acute and chronic inflammation or lymphocytes or organizing pneumonia when you biopsy a peripheral nodule? If you have an elderly person with COPD and smoker and a spiculated nodule and we get organizing pneumonia, is it diagnostic? Maybe it is, but it will require follow-up, right? We can't tell for sure. Maybe it's just an epiphenomenon, around the lesion. So that's why we see a lot of variability in diagnostic yield. And without spending a lot of time, different studies have different definitions on diagnostic yield. The most conservative one is that from the Acquire registry by David Ost. That's why they show the yield of navigation bronchoscopy of only 40%, is because they did not allow for follow-up. It was either you get cancer or you get a specific benign. At the time of the bronchoscopy, no follow-up. The ION paper, the first one by David Fielding from Australia, with the ION system, intuitive system, they included benign, but both specific and non-specific. So therefore, their yield was in the 80% range. So, I'll give you an example. For instance, this is a patient that we had that had this groundless lesion that eventually became solid. There was a bronchus sign. We navigated with a robot. We got organizing pneumonia. And then, 2 months later, it completely disappeared. So if we use the definition that was used in the Acquire registry, you didn't get the very specific benign diagnosis, you're suspecting cancer, that may be considered a non-diagnostic intervention. You need follow-up for 1 or maybe even 2 years in order to truly decide if a lesion is benign or malignant. And in this case, the moment it resolved, that then you truly had a benign diagnosis. The other major thing that impacts diagnostic yield in the literature is what people do with patients who are lost to follow-up. If they were lost to follow-up, are they excluded altogether from the analysis? Are they considered true positives or true negatives? And that's why we see a lot of variability. I think that the healthiest definition of diagnostic yield comes from a paper that was published by Gerard Silvestri in the benefit trial in publishing Chest. And by the way, the same definition was used in the intuitive paper that was published by Memorial Sloan Kettering, also in Chest. So 2 papers, one on Monarch and one on ION, using the same definition. Basically, you get cancer, you have a diagnosis. If it's a non-cancer, but it's specific, either granuloma, fungal, you have a diagnosis. Everything else will need to be either confirmed by surgery or resolution on follow-up imaging. So with the Monarch, this is the data. This is the first study that we published a few years back in 2019, was 165 patients. We showed a yield of 70 to 77%, depending on what we did with the inflammatory cells. If we considered inflammation as a true diagnosis, the yield was 77. If we said that's a false negative, then it was 70%. Very first experience with the Monarch system, like the very first cases that we did were included in this analysis. What was really interesting though is that there was no difference between the so-called concentric view when the radial probe was inside the nodule versus adjacent, which is different than what we knew before the robotic technologies. So that's probably because once we're at the target and the lesion were stable there and we start working there, we can orient the instruments in different directions and we eventually get a diagnosis. This is the summary of the benefit study by Dr. Silvestri. They were able to navigate to the lesion 96% of the time, but the diagnostic yield was 74% with a very strict definition again. With some of the ion papers, people were more liberal with their definition. I mean, they included a lot of inflammation, and they also use other technologies like cone beam CT, and therefore you may see the yield as being higher, but that doesn't necessarily mean the technology is better. It's just the way people define diagnostic yield. This is the paper from ION from Memorial Sloan Kettering I referred to you recently, with a very good definition of diagnostic yield, showing a yield of 81%, although even in their paper, in 20% of the cases, they use the cone beam. And this is our paper that just came out with 1 year of follow-up. It's published in Annals of Thoracic Surgery. We show the yield of 77% at 1 year. But if you get a radial EBUS image, the yield is 84%, again, with no difference between the eccentric and concentric view. And that's my last slide on the diagnostic yield before we go into some examples for a minute or two. Definitions matter. We wrote a research letter in CHEST just recently. I invite you to take a look at this. Every time someone talks about diagnostic yield in bronchoscopy, the question we need to ask ourselves is what kind of definition did they use? Because we found about 5 definitions in the literature, and using the same information, the same patient population, the way you define diagnostic yield can show a change in the diagnostic yield by 20% or more, just based on the definition, which is unbelievable, because that may be all in the methodology and may have nothing to do with the operator or with the technology that we're actually using. And this is a summary of every paper that has been published on the robot to date. Above the orange line, below are the ones in the abstracts. What I really think is fascinating, though, is how often we get a radial EBUS signal. So regardless if it's the Monarch system or the ION system, it looks like these robotic technologies take us to the lesion confirmed by radial EBUS almost 90-something% of the time. So then why is the diagnostic yield dropping by another 10 to 20%? I think is because of what we do at the target, what we do once we're there. So this is an example. Very peripheral nodule. It was a mixed ground glass solid. So they had a solid component, but some ground glass. And you can see there was no clear bronchus sign there. If I can play the video, it's not running, but there was actually a vessel going into the lesion. So we navigated to the lesion. This is the robot system parked at 2 centimeters in front of the lesion. So this is again the sheath that has an outer diameter of 6 millimeters, and then the scope goes through further out, and then we insert our instruments. And we do use rapid on-site evaluation, cytology evaluation in all cases. And then once we get a diagnosis, then it's all a matter of, do we need more for moleculars, for PD-L1, etc. But we always start with the needle. The other thing we learned that for these lesions where the CT and the PET scan don't show mediastinal adenopathy, so we have a low suspicion for mediastinal lymph node involvement, we start with the periphery of the lung. Because, as I said earlier, the longer the time under general anesthesia, there may be more and more atelectases, and that atelectasis can be so significant that it may actually obscure the lesion, even when you look with the cone beam CT. So again, a couple of papers show that. So we want to avoid that. So the moment the patient gets intubated, we go to the periphery of the lung, get the biopsy from the periphery of the lesion, and then we come back and stage the mediastinum. I believe, and this is one of my last slides, that vision in the periphery when we work a target matters, because once we're there and we insert the radial probe, we can define the relationship between the radial probe and the airway wall, which is not anatomically correct. The way the image is projected on the screen is not anatomically oriented. For instance, look at this. I'm in the periphery of the lung. I put my radial probe here at 7 o'clock, if you imagine this as a face of a clock, so 7, but the image on radial IBUS is projected at 12 o'clock at noon. So my instruments, you know, if I'm not aware of this, my instruments could go at noon, but the reality is the lesion is where the probe touches the wall. So that's what I need to orient my instruments. How can you do that without actually having that vision? I don't know. But for me personally, I think having vision as working at the target matters. What we do, we start with needles, about three needles at least, and then we follow by biopsy. And we always use rapid on site. And by the way, needles are important to use. It's interesting that in the acquire registry, before the robots, the needle was only used in 16% of the time, even though by itself, doing a needle in the periphery of the lung can give you a diagnostic yield, and 10% of the time when the biopsy is actually negative. So it's important to do the needle. And it's reassuring to see that all these robotic papers published to date with both systems available on the market, universally they use the needle. So we're getting better in terms of what we do in the periphery of the lung. And I know I went 5 minutes over time. I apologize. I want to thank you again for having me part of your meeting. This is University of Chicago Hospital. If you come to Chicago, please visit us. That's downtown. And my bronchoscopy laboratory is here somewhere with a beautiful view of downtown. Thank you again. Any questions for me while we still have a few minutes?
Can you hear me, Tim?
Very well, yes, thank you.
Perfect. Thank you very much for your very...
Thank you. If there are questions, happy to answer any questions. If not, I will allow you to proceed with your meeting, and I will go to the CHEST headquarters. We have a course going on today. We're teaching therapeutic bronchoscopy, but happy to take any questions if there are any.
I have one question.
Please.
Yeah. Is there any difference between the duration of the process between two modalities, Ion and the Monarch?
Well, I do not know. That's the short and honest answer, because I am not an Ion user. Both procedures require planning the case on a computer prior to doing the intervention, and both procedures require setting up the system. It's a matter also of training the team and the nurses. In the beginning, when we started, it was taking about 20 minutes to set up the robot. Now, I walk into the room and it takes them about 10 minutes to do everything. Like with anything else, you know, the more you do, the better you get. I don't think personally, from speaking with my peers, that there is a major difference between the two. I also think it depends what people decide to do when they do this intervention. If you're talking about duration of the case, I think it really depends on how thorough they are in the staging the mediastinum. 100% of my cases that get confirmed as cancer, we do staging now, even when they are small and peripheral, because we don't know if the surgeon decides they are not candidates and then they need to go for SBRT. So we want to make sure they are N0 disease. So we do staging. There is actually a very recent paper, very recent, that was published in Chest that showed that the location of the tumor may not matter that much in terms of prevalence of the mediastinal lymph node involvement. So, and there is another one from MD Anderson also showing that the same thing. So the idea that you have a small peripheral lesion, less than 3 centimeters, that doesn't need staging if the mediastinum is negative, that may not be the case. I think we're going to do increasingly more and more staging. So therefore, for us, we do staging in everybody once we have a diagnosis of cancer or highly suspected cancer. So therefore, our procedures, honestly, a robotic case, doing the robot and the staging, we're looking at 60, 90 minutes easily. But that is doing the robot, biopsying the periphery of the lung and looking at 3 to 5 lymph nodes. And then we also wait for the pathologist to give us an answer. You know, we call it rapid on-site evaluation, but the reality is if you prepare slides and you wait for them to give you an answer and all that, it's not that rapid anymore. So we're still looking at about an hour and a half when we do staging. If it's just a robot to confirm a metastatic disease, you know, like someone with an extrathoracic tumor that has a nodule and we think it's a metastatic lesion, that could be a 45-minute case.
Thank you very much.
Yeah.
Thank you very much. All
right,
best to chest course. Okay, thank you.
Thank you. Have a great meeting.
Good
and
luck.
Hope to see you soon. Stay safe and sound. Bye.